changes. Those are some of the things that I like to control. Those are the three things, and we're going to come back to that a little bit and later. When I did this lecture last year, I did some research in this article from Panton that was in 1999, and I don't think, other than maybe Dan Taché in the room, who was doing sleep appliances in 1999? So you're doing a few, Dan. I mean, here it is, because a lot of us weren't doing it. I know Mark Murphy were doing it too. And they found out that it's interesting that white changes weren't that important back then. Well, they didn't have a lot of history. And to me, bite changes for me is one of the more common things I see for patients who've been wearing it long. Patients back then didn't have morning occlusal guides like we do today. Didn't have these MOGs. And so we see some of these patients that come to me now with bite changes, and we'll talk a little bit about that when we get to bite changes. There was a Pliska study that talked about overjet and overbite, where overbite was observed to decrease with time while overjet consistently changed. But that study was done over an 11-year period with one type of appliance that was a thermoplastic type of appliance with ball clasps. So we know today nobody really likes ball clasps for retention because the materials are better, and we know that ball clasps can cause open contacts. So I'd like to see that type of study redone with precision type of appliances today. Then in 2017, the landmark article from Sheets and Al came out about side effects. And I like this because it's a good basis for what we do. And if you don't have that article, then again, there's a QR code that you can scan to get the copy of that journal article, Management of Side Effects. And there's things I disagree in there and agree with, and I'm sure we all will agree and disagree with some of it. But it does talk about things like watchful waiting versus treatment. So there's a lot of things that we can talk about. So again, it starts with an examination. And we'll go through this part real quick because we're all doing dental sleep medicine. But some of the things I always want to look at is maxillary midline and making sure it's coinciding with the facial midline, and mandibular midline is coinciding with the maxillary midline, especially when we get our appliances back. We have our exam forms. That's one of mine if you want a copy of my type of exam form. At the end, you just see me at the end and I'll get you a copy of that. And then we do TMJ exams. Of course, we talked about that. John Caulfield talked about balancing the jaw joint first and making sure everything was balanced. And you can't do dental sleep medicine without addressing TMD. And we know that. And so we make sure we do our full examination for TMD. But the other thing he talked about earlier today was we breathe through our nose and eat through our mouth. And nothing is more important than nasal breathing for me to establish that. So one of the things I do is I do a full nasal exam with speculums. I looked in, I went to visit my ENT, and she taught me how to do a nasal exam, how to test for, do a Cottle test, how to do nasal valve collapse. And then we also talk about rhinometry. And later on, if you haven't had your nose evaluated, go by the booth later and have the rhinometer tested from sleep groups, and you'll see how nasal air resistance is so important. So again, I want to make sure that I test the nose first before I even look in the mouth. And then if I need a referral, I'm going to refer to the ENTs that we talked about earlier in the lectures from the previous people on the podium here. So that was Megan taking what the rhinometer looks like. Let me see if I can get that to go back. There we go. That's Megan in my office and using a rhinometer. It takes literally 2 minutes to test. And it measures nasal air resistance with sound waves. So it's uninvasive and it's a simple test. And it does test all the way from the nares all the way to the posterior turbinates, areas I can't see. So if I don't get a good test reading, that's when I'm going to work with my ENTs on these types of patients. And I think the more we know that it's better to breathe through our nose, and John Caulfield had a better slide on this than I did about nitric oxide and all the importance of nasal breathing, we know that that's so important for oral appliance therapy. This next article from Zeng is one of my favorites because it talks about that while we might not lower the AHI with nasal breathing, but it does have a nasal air resistance, has a negative impact on our treatment with mandibular advancement splits. And this study suggests that the higher nasal air resistance may negatively affect our treatment. It's a great article from Zeng. It's from 2008. And again, if you don't have a copy of that, we'll get you a copy of that. So again, starts with initial records, These are things you're already familiar with, so I'm going to go through these rather quickly. Photographs, if you don't take photographs, start taking them, very important. I had a patient one time who said to me, you know, Dr. Carollo, I have a space between my teeth, and I pulled up her scan to show her that the space existed, and then I had my 3D printed models and photographs to show her that that space was already there. She just never noticed it until after wearing the oral appliance. So having all your backup data, whether it's your digital scans and photographs, is so important. Excuse me. And again, one of the things I like is to ask my patients this very first. Have you ever worn something to sleep with in your mouth? Did they wear Invisalign retainers, a flat plane, permissive or non-permissive bite guard, or orthodontic retainers? I find that patients who have worn stuff have less gagging and salivation problems. So I think that's important, because patients sometimes will say to me, how do I know I can wear this? And we go through all that with a different situation. So again, I like this question as one of the first things I ask on my dental exam. Because if a patient says to me, Dr. Carollo, I know my insurance has a high deductible, I don't mind paying for this, but how do I know I'm going to tolerate this? And before we go to anything very expensive, we can make in-office Essex retainers to make. We can make something like one of these provisional splints that are available that can give a little benefit. As a transition, they wear this for 30 to 40 days, so they like it, then we can go ahead with a definitive precision type of appliance. And again, the other thing is about preventing is having proper documentation. Making sure you have documentation and education your patient ahead of time. Today, people are so into Googling everything. I have patients, before I can even talk to them about the morning repositioner, because they're going to get two appliances, the sleep appliance and a morning repositioning appliance, they actually asked me that question. I heard my bite's going to change. What can we do to prevent that? Because I really don't want my teeth to shift. So people are coming into my office with those questions ahead of time. So let's make sure we can answer that. And again, this is the AADSM's informed consent. If you don't have an informed consent, I have one. This is theirs. So, you know, you can always make sure. And here's the key about informed consent. We learned this from one of the attorneys that spoke at a previous dental meeting. The informed is not, this is one of the things I don't delegate to my staff. It is reviewed by me personally, the doctor personally, with the patient, so the patient and I both sign it. And when we both sign it, they get a copy and I get a copy. So again, I'll say that again. Let the doctor review this, patient signs it and I sign it, we keep a copy, they keep a copy. And that has to be on every patient. So again, I also have written instructions for maintenance. So, you know, we deliver appliances 7 a.m. to a busy executive. He doesn't remember how to clean it that following morning. So everything we tell them, we have written down, so they go home with written instructions for every aspect of what we do. If they have some jaw exercises, we have that written down. We have everything done. We talk about their post-op schedule so that patients don't get lost through the cracks. And that's important for me because I am 99% physician referred. And my physicians that work with me, the biggest complaint they have is patients getting lost through the crack and not being sent back to them. So when the patient generates from a sleep physician to my office, I'll do some titration testing occasionally, but I'll have them do the definitive sleep study to show the effectiveness and efficacy. And that's how I do it, especially when the patient is generated from the sleep physician. I don't do the definitive sleep study. Now, if a patient comes to you differently, that's up to you to do, but this is what I do because I have 99% of patients come to me through sleep physicians. And I try to create the patient experience beyond their expectations. So I'll ask them, what are you expecting? If I said to you, how do you define your sleep? And what would it be for you to sleep better? I want to know that. And I learned that from people like Michael Cowan in the back who talks about patient experience. It's not just the doctor experience, it's that patient experience. What do you expect from this therapy? Well, I want to not snore, I want to sleep in the same bedroom with my spouse. Whatever it is, you know, I'm not going to guarantee that. I say, those are the things let's work on together. And these are some of the instructions that we use, and you can have those again in your scan slides, because we follow the patient up in about 2 to 3 days with an in-office texting software. They have an appointment with me about 2 weeks after delivery, but we want to know 2-3 days, are they able to start using it? I don't want them to come back 2 weeks later and say, I never used it for 7 days because I couldn't use it. If they're not able to use it, I get them in sooner. So we're very proactive in following our patient care. 2 days later, I want an update and from Megan or Lily in my office, and then we go forward and get their post-op visits. And I know a lot of people advocate the number 7, where they say after you do a 1-year test, see the patient every year. Well, I change it to every 6 months, especially because I'm not their dentist. I'm their dental sleep medicine dentist. So I don't want them to come back to me a year later with any minor or significant side effect, whether it's jaw soreness or bite changes. I know that if I see it early, I can prevent it or treat it early. So it takes a minute. Now, I'm still doing 50% dentistry and 50% dental sleep medicine. So I have Megan, who's my sleep care coordinator, in one of the treatment rooms doing that 6-month visit, going over all the things that she does with it for that list. And then while my assistants may be helping me make the provisional crown in the other room, I go in and interact with the patient. So you can do this together seamlessly, both in a dental practice and a dental sleep medicine practice. And if you're doing only dental sleep medicine, just have a spare room to do all your post-ops. They don't take long, and they're mostly 90% staff related and only 10% of my time. So again, this is the type of questions that we ask. And we go over this with them. So we send them a text and we ask them, are you able to wear it? Let us know how you're doing with it. So again, we do everything proactively to try to prevent side effects. So again, when I see them on an annual time, I always want to make sure I check their bite and their morning repositioner. And are they using it daily? So if we do have a side effect, let's start with some simple treatment for the side effect. So sore teeth, these are some of the reasons I think we have sore teeth. If the bite wasn't done correctly, if I didn't use my EchoVision bite, if I didn't have a good fitting precision appliance, some of the materials are tighter on teeth than others. Is the midline shift off? Things like that can cause the sore teeth. The other thing, let's go back to the last thing. Poor impressions or digital scans. Some of the better labs will not make an appliance if they think the digital scan is incorrect. And I think that's great. It only happens for me, maybe 1 out of 100. But I'd rather know they don't say, well, we think we can make it. There might be a little, not so good fitting on the lower anteriors. No, get the patient back. Let's rescan them. Let's make this, if we're going to use a precision appliance, let's have a precision impression or scan. Dry mouth, these Biotene products, and that usually resolves itself. And that's nice because they can use that during the night. I get all my appliances with elastics on it. I don't put elastics on every appliance initially. For lip closure, some people like mouth taping. So these are things that can help with dry mouth. And excess salivation is the opposite. Again, that usually resolves itself. And again, it's almost the same treatment. Lip closure, elastics, it usually resolves itself. The patients who usually have excess salivation and gagging are the people who never wore anything to sleep with. It goes back to that one question I asked. Have you ever worn anything at night to sleep? So gagging, there's that gagging question again. So again, one of the things you can even do like we do with dentures, rinse with some ice cold water and put your appliance in 10 minutes before you fall asleep. That makes a difference for people who get used to it. Appliance design is huge. We talk about materials, we talk about lingualist designs. If we can have a thinner appliance that still gives us the right retention, we know it's going to be helping us with these situations that occur occasionally. Open contacts, I don't see much, but the biggest reason open contacts occur is appliances that don't wrap around and engage the distal of the last molars, more lower than upper. I just had a patient come in and he has somewhat impacted third molars to the point I know I can't get my appliance to wrap around the distal of both 18 and 31. And I suggested to him he have his wisdom teeth taken out or a consultation for that. And I showed him why, and I told him the reason we should have it done, and he agreed, and he's going to have that done. Open contacts, ball clasps. If they're clenching and having that sleep bruxing during their wearing of their appliance and ball clasps, I've seen ball clasps cause openings. So again, we're going to try to eliminate that, and all the better milled precision appliances today don't even have those. And lamination. So some of the materials today might be better, but I hate to use the word never and ever, but I never ever make appliances with liners, because today's materials are so much better. I don't want to see delamination, because the picture on the left, when it delaminates, because these patients clean it in caustic materials, and after 2 years, now everybody says appliances will be replaced 3 to 5 years. In New Jersey, I'm finding that it has to be 5 years to the day. I want an appliance to last 5 years because insurances won't pay for a new one. And when these delaminations occur, what does the patient do? Peel it out. As they peel out that liner, now it's only covering the teeth. It's not engaging the teeth. When it doesn't engage the teeth is when you have tooth movement. So let's try to eliminate liners. And again, let's use some precision materials that don't pick up stain. So here you have a picture of a 4-year-old acrylic appliance with a 4-year-old milled precision PMMA type of appliance. And I didn't have time to put the slide in that the patient came in the other day with, but now I have a 7-year-old milled PMMA appliance with a 10-year-old type of Suat appliance that is actually brown. And I said to the gentleman, you actually put this in your mouth every night? My dental assistant goes, I couldn't even touch it, never mind put it in my mouth. It had so much bio-gunk on it. So we want to make these things last. We want to make them not have liners that peel out. That's important for side effects. And this was an article that Dr. Mark Murphy and I did together, and it was presented at a poster at AASM, the Sleep Academy, on materials and staining. And you can see that the medical grade 6 material sets new standards for appliances. And so you can see that these milled PMMAs, and we actually even use the CPAP mask to stain versus some of these nylons. So again, staining is important to me. You know, bacteria getting into our bloodstreams. I mean, Dr. Michael Gelb does a phenomenal lecture on things like that. So I don't want to have that in my appliances. So that's a side effect I want to control. So again, let's go back to some of those 3 things we talked about. The literature talks about therapeutic bite, but you're seeing now in the literature, the AADSM came out with a thing saying, hey, let's talk about construction bite. So whether it's initial mandibular position, treatment bite, can it affect our side effects? And I think it can. So I'm using this for myself, EchoVision. I know you saw the gentleman from the NFL talk about getting his airway assessed. And there's a lot of people that do snore tests that are similar to this, and they all work. But we're finding out that sometimes less protrusion is better for certain patients. We'll talk a little bit in a few minutes about dose and therapeutic position. And this was an article by Kamisi and Hu, and Dr. Kamisi is going to be speaking right after me today. And they did studies where they found out that whether they used a George gauge at a certain protrusion versus an acoustic reflection bite, that it had less protrusion than the George gauge. They used to say to people, start at 50%. Well, I don't start at 50%. And I know some of my friends who even don't use pharyngometry don't start everybody at 50%. They might end up there, but 50%, after you get beyond 50% of protrusion, the side effects, especially TMD and muscle soreness, goes up exponentially. There was a good article by Najor Patel that talked about that specifically. So again, there's these airway metrics jigs that can be used if you're using an EchoVision system. I also implemented these new jigs. These are brand new, optimal air, and they're even more fine-tuned than the other ones. The previous ones had things like 4, 6, 8, 10 type of vertical. Now I have 4, 5, 6, 7, 8. So I'm really fine-tuning it to that 1 millimeter. So I can get a very precise position to start. Now I know a good friend of mine in the back of the room uses a George gauge, that he has different George gauges at these different vertical bites. He puts acrylic on it. So he has a 2 millimeter, 3 millimeter, 4 millimeter. So he's basically doing it a little differently, but still effectively fine-tuning that position. That 3-dimensional bite. And we talk about dose and titration, and this is, again, I want to credit Mark Murphy in the back for letting me have this slide. And he talks about how he does his dose and components on the bottom. And we know that dose is the measured quantity of a therapeutic agent to produce a desired effect, while the titration usually comes from like a CPAP theory, is the continual adjustment of that dose until we get that effect achieved. So we're going to get our patients, and if we can start them at a better position, get better treatment, less chair time, we're going to have a happier patient. The more you bring back the patient and have to titrate 4 and 5 times, the more they're going to lose confidence in us as clinicians. So I found out in my studies, when I've done about 100% of these protrusive bites, I found out that most of my cases, are starting anywhere between the 40 to 50% protrusion range of their total range of motion. And in most cases, about 85% of my patients I can treat within only 1 or 2 millimeters of their starting position. So I don't have to bring them back for a lot of subsequent visits. And that's kind of what I like to do. And again, if we spend the time, whatever way you're taking your bite, if you're going to spend the time to get a good bite, what about having an appliance that's made to that specific bite? And again, there was a study done by Lipcock and Hu where they took various types of appliances, nylon strap, precision, a reverse dorsal, a traditional dorsal, and a fulcrum strap, and these are not mentioned in any manufacturer names on this slide, but you kind of know who they are. And we sent both scans to them, and then we got these appliances back, and we measured them to see if they were made within the accuracy of what we asked them to be. So if I'm going to pick let's just say arbitrarily a certain bite at a vertical and horizontal position, I want that appliance to come back to me at that starting position, or within less than a millimeter of what I pick. And the results came back that only the nylon strap and the precision-made appliance was less than that 1 millimeter tolerance is what AADSM talks about significance for oral appliance therapy. So think about it. You get an appliance back and it could be 4 millimeters or 5 millimeters off, and you're going, are you going to get false non-responders? That term came up at dinner last night. False non-responders. Because your appliance isn't made to where you picked it, is it? And that's important. So I don't deliver appliances that are not within a millimeter of what I asked for. So what do? I take photos and I write down where I pick my appliances, and then I check it on the model. Here's a 6 millimeter from incisal edge to incisal edge, and then I check it in the mouth. If I don't get this accuracy, why would I deliver it? Would you deliver a crown that when you put it in had a big open margin on the buckle? I don't think so. So why would you deliver an appliance that isn't made to the specifics that we all want to strive for? So we're striving for excellence, and we're trying to achieve that without having a lot of side effects, and again, increasing chair time and efficiency. So let's talk a little bit about the more advanced type of major consequences. Tooth movement, bite changes, and T&D muscle pain. I've kind of covered the tooth movement a little bit, but I'll redo that a little bit. And I'm going to spend a little bit more time on bite changes and less time on T&D, and I'll explain that and the why in a few minutes. Again, tooth movement. If you look here, why give me an appliance that doesn't wrap around that molar? If I scan that, why can't you give it to me? Same thing here and here. I want to have it covering and engaging all teeth. Not covering teeth, engaging all the teeth. And that's important to me. And that happens even from a good company. I had to send an appliance back once. They said, oh, I forgot to cover your third molars. If that's in my protocol, I want that, make sure that that's covered. And again, this was the Pliska article that talked about bite changes, where again we mentioned that overbite was observed to decrease with time, and yet decreases at a constant rate. But again, that was a study was done from 2003 to 2014. what about this? So you guys said that TMD was the most harmful problem that you deal with in your offices. So I'm going to tell you mine's different. The room voted that it was more TMD than bite changes. I saw that when we voted on that last question. Why do I not have a lot of TMD discomfort? Because I never over-advance the patient to start. One of the things I might do is start the patient a little bit less forward than I want them to be, and then they wear that for 2 to 3 weeks to get used to it, and then I put them in the next advancement tray to get them to that therapeutic position. I find that that works very well for patients who have a little bit of muscle soreness to start. So I'm not going to put them far forward initially. They might get 85 or 80% effectiveness of that appliance at that little less than perfect position, but then when I get them there in 3 weeks, I know I'm where I want to be. And that's important to me. So that's one thing. The same thing is I see more posterior bite changes. That is the most harmful effect to me. Now, people say, well, if they don't know the bite isn't changed, what are you worried about? Well, this is a patient when it comes in. They're edge to edge. What's happening? They're starting to have fremitus on their teeth. They're starting to fracture lower incisors. I'm going to tell this patient, you come to me, you've had an appliance therapy, you never had a morning occlusal guide, your teeth present like this, and we take pictures and we talk about it. If I make you an appliance, you're honing up to this poor occlusion. Now, I have put plenty of patients like this into orthodontics and make provisional appliances over the Invisalign trays, or they go on CPAP while they're doing orthodontics, getting into the normal occlusion again when, you know, it's like John Caulfield talking about, let's expand and get these people into better bites. And I learned a lot more about that the way you're doing the other myofunctional stuff today. That might be indicated in this type of patient, John. Let's get that fixed first, and we can control the airway with other measures while that's being corrected, and then make a definitive type of appliance. I don't want to work on this patient and be a contributing part of the problem. Now, have I created this in my past? Yeah. I got a guy because of that hasn't seen me in 3 years. We send him, call them. He just doesn't come in. Then he comes in and says, well, you know, the morning occlusal guide you gave me, I never wore. So I said, you know, I should have saw you in 3 years at least 6 to 7 times. So if I don't see you 6 to 7 times, how can I monitor what happened? So this is, hate to say it, all on you. I can help you correct it, but this is what happens. So we don't want this to get to that level. Because there's more than one method. If the only tool in our toolbox is a hammer, everything's going to look like a nail. And we don't want to have that one tool. So again, I learned this morning some things about, you know, how to move teeth in asymmetries and talking about things that they spoke just before lunch on. But I want to control this with a morning occlusal guide. It is the standard of care since the ADSM article 2017. It is part of my practice. We know bite changes occur from stretching of the muscles. And there are a lot of things that patients want and don't want their bite to change. So I again I tell all my patients, you're going to get 2 appliances, the one you sleep with and the one you're going to use in the morning for a few minutes, 2 to 3 minutes. The one in the morning is equally as important, if not more important, than the one you sleep with. Because I can control the sleep apnea in a lot of ways, CPAP or whatever, but I don't want your bite to ever change. And I don't want that to happen, not on my watch. So we know that a patient with a deep vertical bite is going to have less bite changes than the patient who's on the lower left that has more of an edge-to-edge or anterior open bite. It just makes sense because there's not a lot of bite to control on the open bite patient versus the deep bite. And yes, there are other methods that people talk about. You know, these little cowboy things that you make for like $4 on the left and thermocryl on the right, and they make them in the mouth. If the patient loses it or it gets distorted, then their bite changes. How do you make it again? How do you make it again if it gets lost? And what are you going to hand articulate the models? So if I try to make one, again, there's that recommendation again. I put that up there because that's the standard of care for me. Morning occlusal guides are in every case. And so again, I like that milled PMMA morning repositioner. And you're going to see a case towards the end how I do it and where I get it from. So I know that it's going to look good through the entire treatment. So this is that morning repositioner. Covers basically from canine to canine or premolar to premolar if you want a little bigger. And you have that proprioception. So they wear it in the morning. We tell them to wait a little bit. Let's let that synovial fluid dissipate out of the joint. Then we want to make sure they can put this in and not have problems. And then basically you do a contraction and release a few times to re-engage that muscle memory of the pterygoid muscles, and their bite really gets right back. Now, I have patients who don't use it every night and their bite never changes. And I know some of my colleagues who wear appliances say they don't even need it, their bite doesn't change. How am I going to know if that's that patient or not? I don't. So I recommend that they always use it. And it's actually the first thing I check when they come and see me after 2 weeks. Let me see that morning repositioner. Put it in for me. Let me make sure your bite hasn't shifted at all in 2 weeks. Because I'm going to show you a case that did shift in 2 weeks. So again, it has occlusal contacts. We don't want, if it's not going to, if it's lost or broken, we can remake it from a digital scan. This is a newer one that's made. It's more anterior, so it only covers just the laterals. I really like this because you get the canines to touch. It's smaller. It's very concise. It's made out of very strong PMMA material. And if you're going to do this, send 2 scans to the labs. Send a scan with their centric bite so they can make this very accurate. And then send your sleep bite for the oral appliance. And why do I say that? Because some of my friends get lazy, they send 1 scan and then the lab has to hand articulate to get the morning occlusal guide, and then they go, well, it doesn't fit that good. Well, you're relying on the lab to hand articulate your models. If you send the 2 scans, there's no variations, is there? You're guaranteed to have it fit a lot better than if you just ask them to try to do everything from the 1 scan on the right. So again, and this is a conclusion that was done in another article by Dr. Murphy, that digital archives our ability to recreate this model. That's what I like. I want to be able to have bailouts. And it also, when I get them, I get 2 with every case. And that's how it's made with this one company. So here's my patient. I said they came to me after 2 weeks with an edge-to-edge bite. And again, that's their normal bite. So what do? I try chin pushes, and they work, and I'm going to defer to that in a little bit. But I like these bite tabs. I use these bite tabs for the patient. They put the bite tab in, and they try to bite on their back teeth 3 or 4 times. After they bite 3 or 4 times, I slide in that morning occlusal guide, and that, I'd say almost 100% of the time, I can get them right back. As they bite on that bite tab, their own muscles are pushing their jaw backwards. And you're not fighting a force against it. Because there is a video that came out where they're trying to use 2 fingers, and I'll show that in a second. How do you be proactive with biting? I tell my patients to take a piece of Teflon tape or floss, fold it in half and half again. Put it on the occlusal surface that say 19, and bite down. When they bite, they can't pull that floss out. If they pull it out, then their bite is changing. Come and see me. Isn't that simple? It's a simple test for a patient to do at home. Take a piece of floss, fold it in half and half again, and kind of roll it. Put it on number 19 or 30, have them try to pull it out. And I demo this in the office. And I say, if you pull it out, make an appointment and see me. Let's get that bite corrected. So I always want to be more proactive than reactive. And again, this is that AADSM video that came out, and it talked about a little 2-finger push. And to me, the 2-finger push isn't going to get the jaw back. The bite tab works better than that. Because, as I know, for every force, there's an equal and opposite force. So that 2-finger push might work for some patients. There are better ways, and you're going to hear about those in a few minutes. So again, my biggest side effect is bite changes and posterior open bite. So why take a chance? Why take a chance not protecting your patient's bite? If it's significant, then they're going to basically have to have orthodontics or restorative dentistry or possibly surgery. So here's a case on the left. Whoops, I'm sorry, let me go back, let me hit that. This case was a patient of mine that had a lot of worn teeth, and we did a full mouth reconstruction and got a new appliance. This is an orthognathic type case. This is a skeletal problem that probably existed early on, and yet with a bite change got even worse. So that's one of the few times I might suggest MMA surgery, which we know has significant 85% reduction done correctly for certain arts in surgeries. So if the posterior bite changes are so important to me, and hopefully you, why would you not use a precision morning repositioning device or a knob? The last side effect I want to talk about before I show a case and yield to my colleague is TMD discomfort. Now, I'm not going to talk a lot about TMD discomfort because one of my colleagues might be presenting tomorrow. Dr. Dan Tachet's in the room. He might be talking tomorrow afternoon on TMD. And Dan has some great exercises. And I'll show you some of Dan's to help with transient pain. Again, check the midline of your appliance. Did you do a full workup? Are you over advancing them? Do they need to be backed off a little bit, or maybe take the appliance out for a night or two? I wouldn't do if they're a severe patient, but maybe if they're mild and moderate, you might have to discontinue it for a night or two. But I'd rather back it off, use heat, do some exercises, than discontinue treatment. So there is the Dan Tachet chin push. And the reason I like it is because he's got the leaning on the table with the chin down to really push the jaw back. So Dan's in the back of the room. He has his QR codes, and you can get these exercises from. So if you, in the end, if you want to see Dan, he'll have that for you. And I've used these exercises in my treatment. They really help. And again, some heat and ice always helps, and maybe it's injections. If you, whatever you do, and I know, John, you probably do a lot of TMD on side effects too. You have to address this discomfort. Some appliances are made with an anterior discluder. If I know they have a TMD, I've used this maybe about 3 or 4 times, and I do like it. Anterior discluders on an appliance can help ahead of time. If I know it, I'll make it. And I had one case where I couldn't get the jaw comfortable, and I had to bite the bullet and make a second appliance on my nickel with an anterior excluder, and it worked. So now I say to myself, wait, if they have some other problems, I'm not going to make an anterior excluder later. I'm going to make that as my protocol for that patient. So I've used anterior excluders, and they do work. But here's where I check when it comes back from the lab. I want to know if my midline is right. I want to make sure the both posterior pads are touching equally. If you have to adjust them and polish them, do that. The other thing is, on some appliances, the arms get moved. I've seen some of the arms on some of these other appliances where you might have a 2 millimeter adjustment on each side or 3 millimeters, and then 6 months later, it moves. If it moves, it could shift the jaw. I also don't let patients do this because they might move it the wrong way. And if you try to move the jaw forward on one side, and they don't push it forward on the other side, you move it back, you're going to create a midline shift. You're going to actually move the jaw 2 millimeters off. So I don't give the patient the key. I do this myself or my staff. So you always check these type of, and if you're using these type of appliances that have these type of adjustments, make sure it's evenly adjusted on both sides, especially on your checkup visit. All right, so I'm going to finish up with a case and efficacy, and I will actually be done on time, because usually people tell me you'll never get through all your slides in the time that you have, but I think I will. I used to bet lunch on this, Mark, so we'll bet dinner maybe. So here's a case where a patient was on CPAP and they had to discontinue it because they weren't using it. And it wasn't purchased, so the DME provider actually came and took it away from the patient. And this patient was non-compliant, it had to be returned. His AHI was 25, RDI is 31, and he calls up his sleep physician and says, even though I don't use it every night, I gotta have something. So he comes to me and says to me, how quick can I get an appliance? I said, well, it's gonna take about 3 weeks. I gotta have something yesterday. So I made him a temporary EMA first step. We could take 2 impressions right in the office, make that afternoon, and we charge only cash for that, and he gets something to use that night while we're then making the other. So there's his pre-op study showing the AHI and the RDI. I'm sorry, that was the wrong way. And there it is. And we use the pharyngometer to test his airway. We know that his minimal airway is supposed to be 75% patent, but his collapse is over 36%. So these are screenshots from my EchoVision showing that his airway is very collapsible. This patient has 4 millimeters of overbite, 3 millimeters of overjet, and can protrude 9 millimeters. So he has a range of motion of 12 millimeters. That's 3 millimeters of overjet and 9 millimeters of protrusion. You get that? And when I tried in one of the airway metrics jigs, which was a 6 millimeter vertical, and I brought him those 3 millimeters of his overjet just to edge, I improved his airway by 111%. But at 111%, I want to say, can I do a little bit better? So I knew that that was a good vertical for this patient. Let me try to put a little protrusive in it. And when I just moved him 1 more millimeter forward, his minimal cross-section airway increased 179%. And that's where I made his appliance at. And so it was about 35% of his total protrusion. So again, if you're picking 50%, you may have over-protruded this guy and maybe not have gotten a good result, and also maybe have introduced some jaw discomfort. So this is why I use this system, and I know a few of my colleagues in the room are using it. And I use a Prosomnus Evo Flex, nice flex material. You have to see this to believe it. You got to try it yourself. Go visit that booth and see it. And I use that PMMA morning repositioner that I get with this case. And here's that morning repositioner, and here was the appliance. You saw that, the photograph of the 2 cases. And now his AHI is down to 3.5, and his RDI is 3.8. So you can see that we took a 25 down to a 3.5, which is like an 87% improvement. It's phenomenal. He's comfortable, he's compliant, his subjective and objective symptoms are gone. Objectively, we want these numbers to go down, but we also want him to feel better and all his things, sleeping in the room with his wife, to be taken care of. So we know that these 3 effects can also improve efficacy. So we talked about right bite, right appliances, and morning occlusal guides. Now, there was a study that I was part of with Ken Smith and Mark Murphy and Dr. Adai, where we actually treated mild, moderate, severe patients, and you can see the results. We had 100% success getting people below an AHI of 5 and 10 with our mild cases. And you can see how well we did in moderate and severe. You got to remember, we didn't take just AHIs of 30 severe. We took AHIs 40, 45. We did a lot of severe cases. And you can see that our numbers are better than statistically that's reported in the literature. And so we take effect, all these things that we talked about to get to this level. So again, I look at my statistics, my last 60 appliances, and I won't have to read this off for you, you can see it. We get great efficacy when we control things like side effects. If we can create a good position, if we create appliances that are made to the position we pick, if we have stuff that's not going to hurt the teeth or give patients these pseudo side effects, we're going to have success. And that's what it's all about. So my final thoughts, again, they're going to happen, side effects. They're common, they're going to happen. Manage them, treat them, whatever one you think is important. Monitor them. See that patient on a recall basis quickly so they don't become an issue. And most of the side effects are transient that will tolerate. The TMD, muscle soreness, and bite changes are the 2 that are probably the most not tolerated. And be proactive. Let's do things that we can do to change the curve for side effects and efficacy. So again, patient management, John says no matter what we do, it's all about patient care, isn't it? So getting the patients comfortable, getting the patients in treatment, being successful, and being happy. So again, I'd like to thank the Academy for inviting me, and I'll be in the back later if you have any questions, because I don't think we have time for Q&A now. Right? So I will be in the back for Q&A.